Muy buenas noches a todos. Unos minutos.
Hola, hola.
¿Este? ¿Mejor? Sí. ¿Este mejor? Ok. ¿Último? Ok, primero que nada, muy buenas noches a todos, muchas gracias por asistir. Esta noche tenemos el honor de recibir a Armen Baxter, que es el CEO y cofundador de Intellijoint Surgical, una compañía canadiense que nació con un proyecto de ingeniería de la Universidad de Waterloo y que ofrece una suite de soluciones de navegación ortopédica reconocida por Deloitte como la empresa tecnológica con mayor crecimiento en Canadá. Armen ha liderado la expansión de global Intellijoint, una convicción clara de poner tecnología y resultados hacia los pacientes. Y quiero adelantarles las palabras de Armen, que tendremos el privilegio de escuchar nuestro invitado internacional, Dr. Schwarzkopf, okay, del New York Langone Hospital de Nueva York, a quien Armen presentará a continuación. Doctores, con ustedes, Armen, muchas gracias por acompañarnos esta noche y de nuevo, es un honor y que disfruten esta presentación.
Thank you, Armen. Thank you, Rodrigo. So unfortunately, I do not speak Spanish. So Rodrigo could have said very terrible things about me and I wouldn't have known. But it's my pleasure to be here. My name is Armen Bakirtzian. I'm one of the founders of Intellijoint and the CEO of this business. I got introduced to orthopedic surgery by my father. He is an orthopedic surgeon in the US and Canada. I'm trained as a biomedical engineer, and I watched him do a hip replacement almost 20 years ago, and he told me very bluntly, I do this surgery by eye, I'm a human being, and sometimes I make mistakes. So that was our problem statement, and together with my two co-founders, Andre and Richard, we started Intellijoint Surgical officially in 2010. It took us 6 years to develop what you see in front of you today. We've created our own camera that we put into the sterile field that powers both our hip product and our knee product. We also have an open platform preoperative planning solution called Intellijoint View that's web-based for any implant, for any patient. So our business has been around for 16 years now. We did our first surgery in Chicago in 2016 by Dr. Wayne Poprovsky. We have over 75 patents that protect our camera and our clinical applications. Over 75 people work at Intellijoint, and we've done over 85,000 surgeries in 8 countries so far. And it's our mission to create and commercialize technology to improve patients' lives by providing every orthopedic surgeon and their care teams with effective, easy-to-use technologies. So Intellijoint is privately held. You can maybe ignore what's on the left-hand side of the screen. This is probably more interesting to you, is our scientific advisory board. So the second orthopedic surgeon I met after my father was Dr. Alan Gross at Mount Sinai Hospital in Toronto, and he was very gracious at introducing us to many surgeons like Dr. Rand Schwarzkopf, Dr. Wayne Poprovsky, Dr. Peter Skolko, and Dr. Sebastian Rodriguez at Humber River. So we're very fortunate to have a strong group of orthopedic surgeons not only help define problems for us, but help us design solutions, perform clinical research, and ultimately do things like this, peer-to-peer education. So we've got our products here. Dr. Schwarzkopf has some surgical videos that he'll show you today as well. But what we try and do at Intellijoint is create a technology that is fast, that is easy to use, that's easy to learn, that's open platform, that doesn't force you to change your workflow or your implants. Whatever you do today, we want to integrate into your workflow. We don't want you to integrate into our workflow. And that's helped us create a product that's very fast to use. We don't add time to surgery. We don't force you to change your implants. We don't force you to take a CT scan before each case. And that's helped us reach a major milestone of over 85,000 surgeries across multiple countries. So I mentioned we launched in 2016. We launched in the US and in Australia. In 2017, we had performed our first 1,000 joints. In 2018, we expanded into a new relationship in Australia and into New Zealand. In 2019, we did our 10,000th hip replacement. In 2020, we launched our knee product, and we're also the fastest growing technology company in all of Canada. In 2021, we launched our hip product in Japan. In 2022, we launched our preoperative planning solution called View for hips. In 2023, we did our 55,000th joint. In 2024, we launched View for knees. And last year, in 2025, we did our first cases in the Middle East and in India. So I'm very excited here to have Dr. Rand Schwarzkopf. We met 15 years ago, which is kind of hard to believe.
I don't understand it 2016.
I know, but that one didn't count. That was with our first gen. It wasn't illegal. This is being recorded. It was not illegal. We had FDA clearance, but it was not the commercial version of our product. Actually, Dr. Schwarzkopf was one of the first users of Intellijoint Hip, our first generation, and all it did was leg length and offset. It didn't do cup position. And we were really focused on leg length and offset because it's the most common problem in hip replacement surgery. Even if you're a high volume orthopedic surgeon, it's still difficult to get the leg lengths right. So that's what we focused on in our first generation. We met Dr. Schwarzkopf at UC Irvine after his fellowship. I was his rep, actually. And now, of course, Dr. Schwarzkopf is a professor of orthopedic surgery at NYU Grossman Medical School. He's also the associate chief of reconstruction at NYU Langone Orthopedic Hospital. Of course, a board-certified orthopedic surgeon and an international key opinion leader on not only primary hip and knee replacements, but complex primaries, complex revisions. I was noticing some complex x-rays back there. So extreme thought leader, and has done a lot of significant work to advance orthopedic surgery, surgical innovation, technology, and patient outcomes. So it is my absolute pleasure to introduce Dr. Rand Schwarzkopf.
I'll sit because we have some videos. So I'll go over hip and then we'll deviate. I know there's a mixture of, how many surgeons here are hip surgeons? Yeah. And knee surgeons? Everyone else. So we'll have a little bit for both. So maybe you can drink when you're bored. So these are videos that I took of how I do my hip and knee surgeries and how I use Intellijoint. I use Intellijoint for 100% of my hip cases and for a big portion of my knee cases. I use the Intellijoint for every one of my hip revision cases, especially cup revisions. Extremely, extremely helpful, and one of the best indications in revision surgery to use is for cup revisions. So I'll explain it as we go. So we all know navigation, robotics technology is growing. In the US, I think in my hospital, almost 100% of the operations are done with technology, either navigation or robotics. No one anymore looks at the lines of the wall and decides how to do a hip or a knee replacement. Okay, none of you now drive your cars with a map, and I'm sure your pilot in the plane doesn't look out the window to see where they go. They have a GPS, so there's no reason to do surgery like in the Stone Age and looking at lines on the wall. So we should use technology with the navigation, especially in the hip. We get leg length, we get offset, we get cup position. Every x-ray you look at is exactly what you expected. There's no surprises anymore. There's no x-ray, okay, it may be okay, let's hope. Every x-ray looks good. Doesn't mean every operation the patient does 100%. We have complications. If you don't have complications, you're probably not operating enough. So we all have. So this is a case of a patient, a male. I do the STAR approach, which is a combination of the mini posterior and the northern approach. We preserve the piriformis in the cases, and we try to preserve the quadratus depending on the case. So this is the pre-op images, straightforward arthritis, templating. I use Smith & Nephew implants. That's the R3 and the Catalyst, which is the new triple taper collared stem from Smith & Nephew. I had the privilege to design it. And here you can see the use of the Intellijoint pre-planning. So we put in the spine position, we put sitting and standing x-rays. It helps us define a safe zone from impingement, and we can use those numbers. You can transfer them from anatomic to functional angles, depending how the pelvis is standing. I won't go into hip and spine, but if you have questions later, we can talk about that. So the system, as you notice, you have the camera. The camera is mobile. I put it in a pouch next to me. You can see the camera comes out. You'll see in the video how I use it. So you don't have anything that's stable. 2 pins go on the pelvis. And then it's very basic and very quick. It helps, we know the outcomes do well. We know the benefits of it. We've done a lot of cases with it. There's no technology complications. The technology is never wrong. We do define certain things, and you'll see in the video, we define to the system where the pelvic plane is, and that's something we give to the system. It's very important that you do it accurately, or as accurate as you can, and do it early in the case. You'll see the sequence as I do. We've shown that during a hip replacement, in a lateral position, the patient moves a little bit. So if you define everything in the beginning, every movement is taken account into, and it doesn't matter. The system knows where you started, and that's what's important. So you want to do the measurements in the beginning. You can see here patient outcomes done well, leg length restoration, offset restoration. When we do offset, it's very important to understand what offset you're measuring, especially if you start using the system. A lot of patients, we change their version. So if somebody has neutral version or retroversion naturally, now you give him 15 degrees of version, that moves the trochanter from anterior to posterior. It moves the trochanter. As it moves the trochanter, the offset or the shadow of the offset looks different. So you'll see a change of anterior and posterior, and the offset will change maybe less than what you thought, but that's because you changed the angle that it's looking at. So there's 3 planes, X, Y, and Z, of the movement, leg length, offset, and changes from anterior to posterior, and you have to understand how those numbers interact with each other. Okay, that's in all the technologies. Talked about reduced revision, surgical time. So you'll see in the video, I think the use of it adds less than 3 minutes in my operation. The entire use of the things, and that's just adding the time. But think about how much time it reduces it. I trial less. I know with the leg length and offset, I don't have to trial and touch the legs and touch the ankles 1,000 times. I quickly can see the numbers. It makes sense. The hip is stable. I can finish the operation. So you can look here at the operation. Please stop me at any point. Ask any questions if you want. I work with trainees. I operate with a fellow or a resident, and I have a PA. So I have 2 assistants, one I have to teach and one that's been with me for years. I stand on the belly side of the side. Okay, my trainee stands on the back side, or where most people do, because I think I have a better view of that acetabulum from the belly side, and I can control them, and I can hold the leg. So I hold the leg when they do the femur. And you can see that my trainee is doing the approach. I'm putting the pins meanwhile. I make sure there's 2 pins. We're working simultaneously. If you've never put pins on the pelvis, there's a learning curve of, 4 or 5 times until you get comfortable putting them. There's nothing dangerous there. Just don't go too crazy in it, because if you miss them in the too superior, you're coming into the pelvis. So just feel that you're doing them right and put them in. I like putting a little lap around it. It's like when you do for X-Fix. It pushes the skin down. It stops any bleeding that comes out, and then the wounds heal much better and keeps everything clean. So you can see here, I'm registering the side, and now I have to register the pelvis. So the first one registers the position of the camera, gives you 1 axis. And now I'm going to register. This is supposed to be parallel to the anterior pelvic plane. So I'm holding it parallel, and that's it. That was the entire registration. You can see I take off the camera. I put it in a little pouch I have on the side there. And now I can continue my operation. That was the entire registration for this part of the operation. So I think the goal of doing a nice star approach is to have minimal bleeding. You can see here, there's not a lot of bleeding. We split everything very gently. It takes maybe a minute or 2 more, But instead of taking the finger and tearing everything and then asking for a lap pad to hold the bleeding, and then the patient have a hematoma and they feel like they're sitting on a wallet and they're unhappy, this is the way I do it. And then the patients go home on the same day. They don't complain. They walk, they sleep, and they can do everything nice. And we do everything under spinal anesthesia, which decreases the blood pressure a little bit. It helps a little bit with the bleeding, but you can see the field is entirely dry, right? Now I tend to remove everything. I tend to go, instead of finding the piriformis and causing bleeding up there, I actually start from distal to proximal. I find where the quadratus is, and I start exposing from distal to proximal. The head is over here, the foot's over there, and I slowly define where everything is. You can see, again, very minimal bleeding. I don't separate the rotators from the capsule. The retractor is going between the medius and the minimus. We can see now the piriformis. You can see over there on the right. We're going to go underneath the piriformis and expose it, and leaving the piriformis attached up there. And again, I don't separate any layer. Everything comes off as one little layer, and I'm going to tag it with 2 sutures. The sutures I use for tagging, I don't use for repair. I think they get dirty during the case. I want to use a clean suture afterwards, so I just tag with a quick nylon or silk. This is a silk. I put 2 tags just so I can help and retract with that if I need to. You can see a very small. So this is the Intellijoint base plate. This is going to be used for the leg length and offset. So you can use the system without this if you're doing a cup revision and you don't have to really measure the leg length. You can only do that acetabular portion. But if you want to do leg length, you have to do that. I hold the leg in neutral, and now I do range of motion. It finds the center of the femoral head. And it's all based on a magnet there, so I'm going to remove it. See, I remove it, we're done. Now I do a step that I like to do. I'm just using the probe to calibrate it, and I'll show you what I use the probe for. So that probe is needed when you do revision cups, and you'll see in a second. So now we dislocated, cleaning a little bit around the head. I do all of my neck cuts straight to that saddle of where the superior area of the neck comes towards the troch. And cut the head. Again, with the head, I don't just pull it out and destroy. I usually retract it a little bit and remove this. I release the soft tissue, so in the end it comes out without any force. It's all about not causing trauma, because I have to compete with this stupid approach that's called the anterior approach. So I need my patients to do as good, and they do as good with the STAR approach. But the key is very non-traumatic, non-traumatic. We're doing a hip replacement. But avoid any bleeding or hematoma formation. That's the key, right? So you can, my retractors, there's 2 retractors, one on the bottom, one holding the trochanter, and a large Gelpi that's holding the capsule and holding the anterior tissue, and it gives a nice view of that acetabulum. So it's not a big incision, offset reamers. And I don't use the Intellijoint for my reaming. Some people like to use and see the direction they ream. I personally ream at 50 and 10. I ream that acetabulum in the angle that acetabulum is looking at me, and then I position my cup within the hemisphere wherever I want to. I don't believe I need to ream in the exact position of where I want the cup. So now I'll do something like you do in a revision. So imagine that's an old acetabulum. That's my trial. I touch at 3 points, and I see what angles I get. I don't chase to position it where I want it. I just want to make sure the numbers I see make sense. So I look where it is. I think in my head what angle I put that trial in, and I touch it. I don't waste time moving the trial for the right position. I just want to make sure it makes sense to numbers I like. Then again, the cup comes in. I start hitting the cup at about 50 and 10 just to get it inside that acetabulum. Again, it's a small incision. I can't come in directly at that 40 and 20 more or less. And then you see I can put that thing, and I look, okay, that's 45 and 22. I'm happy with it or not. I can change. If I'm happy, just hit it home and close, and then I'm basically done with putting the cup in. I like to put 2 screws, one for my fellow to learn and one for me not to forget. So every case gets 2 screws. It also helps me sleep at night. And then we put the liner in. You can see that's acetabulum. If we had any osteophytes, I would have removed them at this point. And then we hit the liner in. And then we're done with that acetabulum. And this is I don't think this is too much faster than how it takes. A little bit, then you can see a small incision. can see the Intellijoint base plate there in the corner. Another learning curve with the base plate is to remember where you put it so the Charnley doesn't grab it when you rotate the hip. So if you feel something hitting, it's probably that. Open the Charnley and make sure it doesn't pull it out. It will take you maybe once or twice you pull it out by accident to learn not to do it. This is the broaches. They're diamond edges. They're compaction broaching on 3 sides, and 1 side is cutting. So I'm standing holding my leg, and you can see one of my hands there is guiding the version and guiding my resident how to put it in. So that's my hand probably that you're seeing, and he's hitting it in and out.
Did you use a neutral liner or a 10-degree?
Maybe that was a 10-degree. That's why they had the marking there. It depends on the case. Depends. I look at the pelvis and the spine. Depends how much risk they are. So I don't just rely on the Intellijoint or on the readings. I'll check, of course, stability. I'll bring it through range of motion. I'll make sure I'm happy with what I see. So again, you do the center of rotation. Then I can see it looks like length, offset. So for me, that will be okay. I like that stem. I'll probably just use a +4 head. That'll give me the 2 extra millimeters in length, the 2 extra millimeters in offset. I think most patients with arthritis should be about a couple of millimeters longer and more offset than what they came because they lost cartilage. There's a reason I'm doing surgery. They lost some height and offset, and I should give it back to them. So again, you can trial, you can play. You can see here the anterior-posterior change. That usually equals a degree or 2 in offset. So every 2.7, 2.4 degrees of anterior-posterior change is usually an offset millimeter. So I clean with betadine, we change gloves, and now we repair back the capsule with non-absorbable sutures. I run 3 of them, 2 in the capsule, 1 in the conjoint tendon, and then we do 2 burr holes in the femur, and we'll pass them and close. So I know all of you probably had some resident or fellow do something wrong. I had a fellow once when I was not in the room, put the suture through the sciatic nerve. Since then, I put the sutures in. None of my fellows get to put these sutures in, and that's what I do. And then we pass them, and instead of wasting money on a suture passer, I use a Keat needle with a PDS suture. It's a cheap man's suture passer in order to pass and close everything back down. And then I tie it, and then usually I can leave the room and go to the other room. So overall, not too big of incision. I still use, because of different research reasons, I still put a gram of Vanco in the deep. Probably doesn't do anything. And I use barbed sutures for all the different layers. It's probably been a long time since I've seen this part of the operation. At this point, I'm already half finishing the case in the other room. So it's barbed sutures across the top, and then let's see what dressing they put on. I'm curious. And then, oh, this is silk. See, I got some silk in here. On all of my dressing, it says when to remove, so there's a date, please remove on, so the patient can know when to remove it 1 week after surgery. So that was the hip. That's the post-op. Follow-up 3 months later. So we know it helps us when we use technology to decrease the dislocation rates together with the long heads now. Yeah. You can't see directly varus or valgus, but you can see the offset, right? So if you have a lot more offset than what the stem does, that means your stem's in varus. If you're missing some offset, maybe the stem is in there. Because another part of information you get there is the changes in center of rotation. So if you put your cup too lateral, let's say you had a lot of osteophytes, and then you put the cup and you do the measurement, it says you're 4 degrees lateral, that means you probably didn't go as deep as you wanted. If you have 10 millimeters too deep, then you went much deeper, so you can think about it. So you get a lot of nice information from the screen when you do it. You can go back and correct. Different total hip methods. We publish robotics versus navigation versus conventional. No big difference between navigation and robotics in total hip replacement. Both of them better. So I think the important thing is to learn the system a little bit, and it helps you learn better. I now know from where I stand on the operating room, if I bring the handle down, the cup gives me a change in inclination and version, almost 1-to-1, because I got used to whichever angle I use. From looking at the system for so long, I know how to do quick changes of position, and I know also how to look at it and know what I have. So it really makes me a better surgeon if I don't use it. And the way to use it in the revision is before you take out the cup, you come to the cup, you touch 3 points, it gives you a number. It tells you where the old cup is. Because by the time you take out the old cup and try and put a new cup, you don't even remember where the old cup was, and you put the new cup exactly where the old cup was, and you want to change it. So it doesn't matter which numbers it gives you, the delta difference between the old cup and the new cup you put in is accurate. So when you did your plan before the revision, because this was an instability and you want to revise the cup and add 10 degrees of inclination and maybe 10 degrees of version, so you see the numbers, let's say it said 50 and 15, you have to go to 40 and 25. It doesn't matter if that number is real or not, but the delta is real. So you can see what you had, and you can go to where you planned and put the new cup exactly where you want it. So for those cases, it's amazingly accurate. So let's look at the knee. So on the knee side, a navigation that helps you decide both on the coronal and on the sagittal planes where to put. You have different ways how to use the system. You can use the system with a cutting guide that you can adjust. Or you can use it the way I use it, which is without the adjustable cutting guide, a quicker way. I've been using it for so long, I got used to it. And you can see all the different angles you get. The accuracy was verified, so I'll show you the way I put the pins. So you can put the pins in a way that you can verify your cuts. I did in the beginning when the system came out. I did 40 cases where I put it like that. I verified that my cuts are what I was told, and then I said, now I trust it. I don't need to verify anymore. So I put my pins in a way that I don't make new holes in the bone. It goes exactly where you'd go intramedullary. And you'll see it in the way I do it, because I don't verify my cuts after I cut them. So again, the advantages of doing a navigation, the time, you'll see the time in the case. It doesn't add almost anything. It's probably quicker. My navigation case is quicker than a manual case, because it takes away some of the steps that I have to do. And then survivorship, we know it's better.
My patient is a 64-year-old
close the
female
volume?
with primary osteoarthritis of the left knee.
The preoperative plan was to do a femur varus cut with 0 degrees to the mechanical axis, a femur flexion of 5 degrees, a tibial cut
the most
of a
arthritic
0
knee.
varus
I
valgus
apologize.
coronal plane cut, 8 degrees of posterior
This came from
slope on the
HSS, it's
tibia,
not mine.
due to this being a cruciate retaining toe knee arthroplasty, and resection depth 7 millimeters off the medial side. This patient in general has a more valgus knee that can be seen on X-ray. Patient is overweight and obese.
So the way I use it was evolved over time. So I use a combination of using some of the jigs to make me faster using the system and more accurate. I don't like holding things in the air and trying to look at a number and shoot it. I like when things are stable and easier for me to use. So proximal, distal. The camera for me sits on a Mayo stand next to the foot. There's only one part of the case that it has to be stable when it captures the first array. So at this point, you can see where I put the pin for the Intellijoint. I put it just lateral
onto the bone screw,
to the
angle it
center,
towards the
because you
camera,
have to tell the
and secure
system
it.
where the middle
Next,
is.
I
can't
rotate
have
the femur
pin
through a
exactly
range
where
of
I want the
motion
mark.
to capture
So
the
at this
hip
point,
center
the
of
camera is
rotation.
sitting stable on
You
the
need
Mayo
a wide
stand
range of
on the
motion
side.
and avoid
This is actually, I
hitting
think,
or
an older
tapping
software
the
version of
support
what we have
area
now, so now
of
it's a
the
lot
knee if you
faster.
place one next to the thigh.
It goes a
I
lot
use
quicker.
a
You can see
probe
the camera
tracker to
shooting.
capture the
From this
center of the
point,
knee,
camera just
defining
gets
the
held
mechanical
in the
axis
hand
of the femur.
One of my assistants. It doesn't have to be stable. There's no line of sight. So
I
that's
define
point
the
you're in
white
the
side
middle.
line by
So don't
aligning
put
the axis
pin
of the probe tracker to the
exactly
white
where you
side
have to
line.
get that mark. So center of rotation. Now I define
Using the
that zero
probe
posterior
tracker, I
axis.
paint a single line on the
At this
lateral
point,
and
the new
medial
software,
condyles to
instead of doing
define
a
the
line, you
articulating
paint,
surface.
and it chooses the most distal point on each condyle.
Femoral
So you don't have to tell
registration
it what's
is
most
now
distant.
complete.
It would choose it itself.
Next, I assembled the cutting guide and paddles. Intellijoint knee is an open platform system, so you can use the provided cutting guide or the cutting guide of your choice from any major implant vendor. The probe tracker magnetically attaches to the cutting guide of choice. Real-time measurements are displayed for varus valgus, flexion extension, and resection depth. I first aim for optimal flexion, then look at the varus valgus, then the resection depth, securing the guide at each step with a smooth bone pin on pound.
From Latin America, they're Asian, they're Caucasian. And then my second pin.
Measurements are saved to summary screen. I remove the bone tracker and pin and proceed with the distal femoral resection. You can then proceed with your standard surgical workflow. For this total knee arthroplasty, I used the Smith & Nephew Journey 2. I used the 5-in-1 cutting guide to complete the implant-specific femoral cuts, then proceed to tibial registration. I install the bone screw into the articulating surface of the tibia, angling away from the femur. I put it adjacent to the center of the tibia, then slide the bone tracker onto the bone screw and secure. I define the mechanical axis of the tibia by probing the lateral and medial malleoli and the center of the tibia using a probe tracker.
Medial point axis on top that defines the axis of your tibia. And now you'll define the
I define the AP axis by aligning the axis of the probe tracker. I complete the tibia registration by probing the deepest points of the medial and lateral tibial plateaus. I use the Journey 2 non-spiked extramedullary alignment clamp, rod, and stylus, and cutting block to guide the tibial cuts.
I used my regular jig to give stability. And also to allow my
I magnetically attach the probe tracker to the tibial cutting block. I can see real-time measurements are displayed, again for varus valgus, tibial slope, and resection depth. Once the cutting guide is positioned optimally, I secure it using smooth bone pins on pound.
I'm a CR knee, so my slope depends on on the more of the natural slope of the knee. And then after I define that, I'll do my last pin. Again, I'll check it. And then I'll put it. You can use the smart jig. You can use other things to kind of capture, to define what you want. So this patient got 7 degrees of slope.
The measurements are saved to summary screen. I remove the bone tracker and pin, then complete the proximal tibia resection and the surgical workflow. Positioning and sizing the implants and assessing flexion measure. Post-operatively, you can see the implants have been positioned for optimal joint alignment.
That's it. Any questions?
Revisions. Can you use it in revisions?
So you can use it for the same thing. You can do the cuts. But it won't tell you how much to cut you have to define, but it will give you the axis of the cut the same way. There's no problem with that. You just have to decide where to put the pins. You can't put the pins exactly where I put them, but you can put the pin wherever you want. There's no rule where the pin has to be, as long as the camera can see the array and see the other array that you use, right? So they just have to be pointing in the same direction. Or just bring the camera. You can bring the camera to wherever you want, right? So you can use it to cut the tibia again and do the distal cut.
How do you recut if you remove your...
I don't recut, so... Not with that. If I take out the array, then I can't use it. But if you'd made a flat cut, remember I used a regular jig.
Yes.
So the jig, I can just put the pins back and take the jig down 2 millimeters, right? It's still going to be the exact same axis. So my recap will be the same. Anyway, this is by hand, right? So I'm still using my regular cutting jig. I just positioned it together with navigation. So if I'm unhappy, just keep the pins. So what I do in my case, my sequence of events, after I finish the femur, then I cut the tibia. I leave the 2 pins for the cutting guide on the tibia, and I check my gaps. If my gaps are fine, then I take the pins out. Because if I need to recut, my pins are still there, and I put the cutting guide back in.
Yeah, but that's for a deeper recap. But if you want to change your power values of your tibia,
you can't. You have to do it by hand. Each company has jigs. Like the company I use has a jig of 2 degrees. If I want to use that.
Okay. What happens if you lose the disc on the femoral part? You have to calibrate everything again.
It depends. If you cut the femoral head, you're done.
Oh,
If the disc falls off the femur, you're done for like an offset if the femoral head is cut, because you can't unless you put it back in the same place for some reason. If you can identify where it is, right, it does have a screw, you can try put it back in the same place, but just remember it fell off, and it may not be as accurate. The acetabulum you can still do. As long as the pins on the pelvis and that state, you can do an acetabulum. For the leg like an offset, you need the disc on the femur. But I can tell you it rarely, maybe once a year now it may come out because I didn't pay attention. But you just have to learn where to put it well on the bone, just a small little learning curve, and be careful with the charnley, especially if you do small incision. Any other questions about anything?
Yeah, you take your data with the brooches, right? Mm-hmm. And then you take another measurement with the final implant. Mm-hmm. Have you ever found yourself maybe hitting too hard the final implant in order to get the same measurements of the?
So I never hit my implants too hard because then you have fractures.
Yeah. Right. Okay. That's why.
So I never do that.
If you make your measurements with the brooch, you wanna get the same measurements.
So, but that has nothing to do with the navigation. That has to do with the implants you use. Yeah. So then change implants to better implants that sit where the brooch was.
Yours didn't. Yours was a little bit proud.
Yeah, but also my brooch was a little bit proud. So I don't try and get my the stem to sit all the way down. I don't need my collar to sit down. The triple taper stems don't need a collar, right? So if my neck cut was a little bit too low and I needed to have the brooch sitting higher to get my leg length, then it will sit higher, then my stem will sit higher.
Okay.
Okay?
In terms of that, do you just plan to get the collar? Talking about that, do you just plan to get your collar a couple of millimeters?
No,
in
I actually don't pay attention to that too much. I cut my neck at the same anatomic relationship to the greater trochanter. I like cutting my neck always at that saddle area. In most cases, that will bring my my collar to the right place, or even I have to calcar ream a little bit to bring it down so it sits flush on that. But now and again, you'll have valgus hips that if you sit at that level, you're too short. So I have to go to the next size stem, and it will sit higher than the cut, and I'll just ignore it. If my brooch set to the right line, and my stem is sitting a few millimeters high, from my experience, it goes down to, after the patient starts walking, it tends to go back down. It means usually that either my version, the angle was not 100% accurate, and I had a little bit of an angle on it, or pushed it a little bit. Most times it finds its way back down to that, because that's where you prepared it with the brooch. So it's usually an angle thing, and sometimes it corrects. So I'll sometimes be okay if it's a little bit longer than I planned, because most cases I find it going back to where the brooch was. And I rather the patient pushes it down slowly than me banging it in the wrong angle.
And when these things start to fail, how do they fail? Do they start maybe your cap?
What's failing?
I don't know. I'm asking your experience. I don't know. If something fails in this, you will end up with a cap maybe facing completely forwards.
So the only way that this can fail if you put right or left, but instead of right or left, and then the numbers will be completely upside down. Which I think I remember once happening in the last year. My fellows clicked the wrong left or right, but then the numbers I just did minus 108. I just looked at the numbers opposite, right? There's nothing for it to fail in that acetabular cup, unless you gave it wrong information. You registered something wrong that made it inaccurate. On the femur, you can have issues because the femur, you're supposed to put the femur in the right angle and hold it, right? With patients that have severe contractions, they're severely externally rotated, and you can't bring them to neutral. Or they have flexion contraction in the femur, you can't bring the leg to neutral. So you capture whatever that patient can come to. After you do the operation, now you can hold the leg straighter, or you change the version drastically. It's not inaccurate, but it changes those three numbers. The leg length offset and anterior posterior will shift a little bit the numbers between them, because this is based on a 15-degree anteversion, right?
Yeah, whatever you register, that would be your base anteversion.
But every change, it thinks as if you were in a certain angle of the anteversion. If your anteversion is very different, some of those numbers, a millimeter, go here. So I know from doing this thousands of cases, I know the numbers, what they mean for me a little bit. The way I hold the leg, the way I do the case, I know what the transfer a little bit between leg length and offset is because how I hold the leg and what contraction the leg has. So it's not anything that fails or inaccuracies, it's just because of the deformity and the way you tell it.
Okay.
But I managed to get many surgeons to stop taking intraoperative x-rays and trust this and come out of the operating room fine. The only thing I would say, the only thing, at least in my hands, I don't chase the offset numbers as much. Meaning if I use a high offset stem and I know how many millimeters it is, because that's how much it's designed, and I templated the patient, and I templated a certain amount of offset, and now I put this high offset stem and it says -3, I don't think I'm lacking offset, because then I look at the anterior posterior change, that means the version changed a lot. And then I have like 8 change in anterior posterior. So then I know that's at least 3 or 4 millimeters of offset. And if you change that offset, you'll have a lot of offset. So it's understanding what the information the system gives you. I lost all the knee surgeons are sleeping.
And when you use
I say offset, they're thinking about hybrid stems with offset. Yeah.
when you use the liner, the 10-degree liner, I don't know if that is also a phase-changing liner.
No, I don't use phase-changing liners.
Okay, and if I do, does it take into account this?
How will it take into account the phase? You take into account.
Yeah, I know.
Yeah, that's good.
This is.
Do you know mathematics?
Yeah.
Okay.
I think so.
So how much the phase-changing liner adds to your anaversion, you know.
So
you know where to start.
I will have to take my chart. So this is
Just
why.
If you're using a hemispheric cup, it will tell you where you position your cup. Whatever you put in the cup, you have to know. If the phase-changing line, first thing, there's no reason to use a phase-changing liner in a primary case. Just put the cup where you want it. Right? You have numbers here, you can position the cup. There's no reason to use a phase-changing liner. A lot of the companies are taking it away. They're no longer going to manufacture phase-changing. In revisions, I also don't use those. I usually, when I do super complex revisions, I use a fully porous cup, and I'll cement into it a dual mobility inner cup that's meant for cementation. And then I put it in whatever position I want within the porous cup. Okay, so I separate the two things. And I can use the Intellijoint because I can see where the porous cup is, let's say 55 and 10, and then I cement the inner cup inside at 42.25. And I can touch the inner cup and see that it's accurate. I use the probe to check the inner thing. So in the phase-changing liner, if it has something that it will tell you where it's facing, you can take the probe and touch 3 points and see where it gives you. Do you understand?
Yeah, great. Do you have any videos of that?
I have videos of that. You can also see online. I have videos of how I do the read that porous with the polar cup inside, and you can see how I touch it with the Intellijoint. I don't have my computer here, but I think I have them online.
Ron, we are doing kinematic and functional alignment right now.
I don't believe in kinematic alignment. I think it's bullshit, but I do functional alignment.
Okay, so here you don't have the numbers that you have the robot to check them. So.
Yeah.
What it changed in your perspective when you're doing Intellijoint?
If you want to do kinematic alignment with this, then you have to use
functional.
So you can put whatever numbers you want, right? You can put 2 degrees varus. You can do whatever you want the femur. So you can put all the numbers. The gap balancing, you have to use some device to do your balancing to make sure you're happy.
So do you see any difference between your robotic surgeries and your Intellijoint surgeries, or it's not perceptible?
If we look at the patients, no study showed any difference with the patients, right? And also because in robotics, I'm not kinematic, I do more functional. So I don't do a lot of changes in the femur. I'll change a little bit of varus knee, so I can do the same thing here. Any other questions?
You need to still use this?
Yeah.
You change?
No, I use both. Yeah. Everything has its benefit depending on the room, the trainee, the facility where you work. For example, in contracted valgus knees, the robots don't really help because you have a contracted side. Until you release it, you can't even do balancing. So then you're just using the robot as a navigation device.
This is very useful for obese patients. When you need to
Yes. Yep.
triangle patients, 90 years old.
Patients that have bad range of motion, you can't even register them on the robot, or bad deformities. This gives you the perfect cuts that you need. You can use it with hardware, right? You just put the pin somewhere, it doesn't hit the hardware, you can do your cuts. You don't need any intramedullary guides. Any other questions, or everybody wants some alcohol? If anybody wants to see the instruments or the demo, I'll be here. So here, come. So if you put a cup in, you put a face change line, just touch the cup. 3 points, that's how it is. So you can do the cup first. So the cup you did with the impact, right? Or if it's a revision, you go 1, 2, and 3, it tells you the number. And if you have the line on the side in a different angle, you just go 1, 2, 3. Okay, well, better late than never. Whatever you want is a different angle to the trial. So you can put it and see where it is. You can take as many as you want. You can actually, they have a back window. Can you see that back window so you can see multiple measurements? Yeah, are your trials? Yeah, can you bring it up? Yeah. So you can actually go to an inner screen here. You go in, you can try 6 or 7 times.
You want to see your trials, or sorry?
Like if I try 3 different options, you can keep all the numbers, right? You want to just calibrate the So from this point, if you pull the patient like this or like this, it knows that. You can see. So another nice thing that it does in the operation, remember, let's say we were tracking the femur, and whoever positions the patient didn't position the patient well. The patient starts moving. And all of a sudden you go in and you put the cup and say, this looks good, but it tells you it's only 5 degrees. Then you go here and you say, oh, the patient moved 18 degrees on my table. So you know now it's going to be difficult to put the cup because everything is in the way, or somebody can come in and push the patient back. But it's actually very interesting. Let's look at it when we go to the reaming stage. So here, so let's say this is a revision. We go 1, 2. Really good, really good. Yeah.
And 2. You need someone that's pressing the button.
I can do it from here. Okay. I can do everything from here. He's just helping. So this cup is 52 and 5, okay? So let's say you want to do it, you want to revise it and do it better. So now you ream. You don't have a reamer here, but let's imagine.
No, you have a fake impactor there.
So let's say you're reaming. Let's go to the cup placement. You're skipping that? Okay, so you're skipping the femur side. Yeah. So here, cup position. So I can ream. I can put the inclination. And you can decide, okay, here you want to ream or you like it. Or you can decide now where you want to put the cup, right?
That was the previous data that you put in.
Yeah, that was a cup we took out.
Okay.
So now I know where the new cup, right? I want to put it, right? The patient was dislocated. You like it here, you hit it in. This cup is really in a bad position.
Yeah.
Can I take this out?
Yeah, you can.
So let's say we put the cup in a nice position here, and then you want it to, so first thing you can verify with the handle. So let's see afterward, you were talking about the face changing liner. So now I can go. And now it'll tell me the new position of the cup, right? And you can see it. So you know the delta is perfect. So you took out a cup, you reamed, you destroyed everything. Now you want to put the new cup, you know where to put it in compared to the previous cup. So that's the tablet. What other questions you have?
And if you have, I don't know, maybe there's a post-PAO patient and you have some deformity over the crest.
As long as you can put the pins here. Yeah, just find a different point on the iliac crest.
It doesn't matter as long as it is in the left crest.
This can be anywhere as long as it's stable. Okay. Right? You can put on a patient's head if you want. As long as the head moves together with the pelvis, right? No, but you want it to be on the pelvis because everything here can move separately, right? So the pelvis will make sure that whatever you capture will always be the same. I never had a patient I couldn't get this in, right? Because the PA was not supposed to go up to here.
No, maybe
that's a very bad PAO.
A pediatric surgeon.
PA was supposed to go somewhere here, right? Even that, usually this area is fine. Even you find a place to put them in. You just want to be careful not to. You don't want to slide like that. Yeah. Right. So I usually find I go in with my pin. I touch forward and backwards. I usually hold my pins with my fingers while I'm drilling. Some people like to use a mallet and start. I don't. I just go with the drill and I just hold it with my fingers and control it.
And this screw, how long is it? The central one?
Do you have another screw?
Four.
Do you have another trochanteric screw?
I can get one for you.
I've never had a problem of hitting it when preparing the food. Okay. Never, not even once. So I don't even think about it. Doesn't matter how it looks, I never had an issue with it.
Have you ever used this system while in a cemented stem? Yeah.
I cement all the time. Still, it's not a problem. And that thing was never a problem.
Nice. I ask too much, maybe.
No, you can play with it.
And do you work in 2 ORs, right?
Yes.
And you have how many of these? 3, 4?
4 in the hospital. No, yeah, 4 cameras in the
And
hospital.
how many trays?
10.
10? Okay.
Here's the taper screw. If you open that, sorry.
We do 7,000 hip and knee arthroplasties in my hospital. A year. Yeah. I do 600, 650 arthroplasties a year.
It's not out yet.
Yeah, so we don't have a problem. Part of it is in here, right? This is thick.
Soon you'll be able
So it's not a lot of leftover.